Thank you so much, Dr. Saad, and welcome everybody for our symposium today, Burn Symposium. And today we have 4 international speakers, Professor Waleed, Dr. Khalid, Dr. Layla, and Dr. Simant, and Egypt, United States, and India. So I am sure you will enjoy this Burn Symposium. First lecture today will be for Professor Waleed Hamimy. He is Professor of Anesthesia, Surgical ICU and Pain in Cairo University in Egypt. And he is going to talk about the airway challenges in burns patient. Welcome, Professor Waleed.
Thanks, Professor Yasser. And I want to thank Dr. Saad for his excellent organization for this symposium. I'm going to talk about the airway challenges that we face in burn patients, and this is a very important topic. And actually, we have many problems in the management of our burn patients here in Egypt. To start with, inhalational injury or smoke inhalational injury remains one of the leading causes of death. Up to 35% of burn patients suffer inhalation injury, which is associated with significant complications. While the treatment of cutaneous burns has improved in the last few decades, mortality rates for patients with inhalation injuries have not changed significantly. The problem is in the management system itself. To start with, by definition, inhalation injury is a non-specific term that refers to damage to the respiratory tract or lung tissue from heat, smoke, or chemical irritants carried into the airway during inspiration. Some statistical data about fires in Egypt, I found it in the web from the World Health or from the WHO, and according to their latest data, in 2020, fires death in Egypt reached 1,568 deaths, which accounts for 0.29% of the total death. And Egypt is ranked the 83rd in the world regarding the number of mortalities from burn and fire. To compare, in the USS and the United States, the local fire departments responded to an estimated 1.4 million fires, and the mortality reached 3,183, accounting for 0.13% of the total death. The United States is ranked in number 124 in the world. Pulmonary complications following burns and inhalation injury are responsible for up to 77% of the death from burns. The majority are due to carbon monoxide poisoning. When to suspect inhalation injury in a burn patient? First, burn inside any closed area makes us very suspicious about the injury of the airway and the lungs. Secondly, if the patient is coming with a disturbed conscious level. Dyspnea, the dyspneic patient raise the suspicion of inhalation injury, soot inside the oral cavity and sync vibration, as well as associated facial burns. Pathophysiology of burn can be divided into airway problems, airway affection, and the systemic toxicity effect of carbon monoxide and hydrogen cyanide. Airway affection, any closed space burn injury, as we have mentioned, involving steam, hot gases, combustibles, or explosions should always raise the suspicion for airway involvement. There are 3 primary mechanisms for inhalation injury: thermal damage, asphyxiation, and pulmonary irritation. Thermal damage from the heated air, asphyxiation from the particulate matter, and the toxic effect from the noxious gases. Heated air from a fire will lead to significant thermal injury, especially to the upper part of the airway. The particulate matter produced during combustion, the soot, mechanically obstructs and irritates the airways, leading to reflex bronchoconstriction and atelectasis and further chest infection or pneumonias. The noxious gases released from burning materials such as carbon monoxide and hydrogen cyanide leads to the systemic toxic effects of these substances. Based upon the primary localization of the insult, inhalational injury is classified into injuries of the upper airway, tracheobronchial system, and the lung parenchyma itself. Starting with the upper airway affection. Burns to the airway can cause swelling that blocks the flow of air into the lungs. The leading injury in this part, in the upper airway, as we have mentioned before, is the thermal injury due to the efficient heat exchange in the oro and nasopharynx. The immediate injury is in the form of erythema, ulcerations, and edema. Furthermore, edema formation is also promoted by the aggressive fluid administration required to treat burn shock. Just to remind you, a modified particle formula that we use in our burn unit accounts for 3 to 4 milliliter per kg per percent burn for every 24 hours. This means that at 30% burn, the patient will receive around 7 liters of fluids in the first 24 hours. This definitely will increase the edema effect. No thermal damage below the coils due to the poor conductivity of air. The temperature of the air drops immediately after passing through the vocal cords, and if we have air with a temperature of 300 or 400 degrees Celsius, when it reaches the lung, it becomes around 40, 45 degrees Celsius. Right. What about the pathophysiology itself? What happens? In the upper airway injury, first, acute inflammation occurs. Secondly, there is damage to the ciliary functions in the mucosa in the upper airway, impairing the clearance process of the airway, leading to an increased risk of bacterial infection for several weeks. And lastly, increased production of thick secretions, leading to distal airway obstruction, atelectasis, and impaired gas exchange. Secondly, the tracheobronchial system, a bit lower part than the upper. The causes of tracheobronchial injury is mainly due to the chemicals in smoke, also noxious gases that occurs during fires as chlorine, and liquids as the acids, rarely direct airway fire, and this occurs intraoperative, for example, when we are doing any laser surgery. What is the mechanism of tracheobronchial injury? Smoke inhalation leads to stimulation of the vasomotor and sensory nerve endings to release neuropeptides. These neuropeptides will induce bronchoconstriction, induce nitrous oxide synthase enzyme to generate reactive oxygen species. They function as tachykinins, inducing an inflammatory response with downstream effects of bronchoconstriction, increased vascular permeability, and vasodilatation. Also, these neuropeptides potentiate the local cellular damage and the loss of hypoxic pulmonary vasoconstriction, increasing bronchial blood flow. The increase in bronchial blood flow leads to flux of activated polymorph nuclear leukocytes and cytokines, increasing the host inflammatory response at the level of the alveoli. Also, the loss of an intact bronchial epithelium and the effects of the reactive oxygen species lead to loss of plasma proteins and fluids from the intravascular space into the alveoli and bronchioles. The exudates formed and the cast formed within the airways lead to obstruction and alveolar prolapse. All these mechanisms lead to ventilation perfusion mismatch, which is the primary mechanism of hypoxemia that occurs in such patients. Lastly, in the classification, the lung parenchyma. Parenchymal injury facts, the most important fact that you should know that damage to the lung parenchyma is delayed. And the time difference from the initial injury to the decrease in the PF ratio is correlated with the severity of the lung injury. This means that faster onset of parenchymal injury occurs with more severe disease. faster time leads to more severe injury. Characteristics of parenchymal injury includes decrease in the surfactant leading to atelectasis. This atelectasis and the alveolar collapse that we have mentioned before lead to increased transvascular fluid flux of plasma proteins and the other polymorph nuclear leukocytes and other cytokines. Also, the loss of the hypoxic pulmonary vasoconstriction leading to impaired oxygenation. Ventilation perfusion mismatch due to severe imbalance in alveolar hemostasis and decrease in the fibrinolytic activity with massive fibrin deposition in the airways. All this leads to the hypoxia. This mismatch is made worse by the formation of nitric oxide and reactive oxygen species, which leads to vasodilatation, increasing blood flow to the poorly ventilated alveoli, leading to more mismatch in the ventilation perfusion ratio. The airway obstruction and atelectasis increases the risk of pneumonia. How? There is impaired function of alveolar macrophages, polymorph nuclear leukocytes, and mucociliary clearance mechanisms that we have mentioned that is impaired by the thermal injury that occurs in the upper airway. This is a figure or schematic presentation of the effect of smoke. All in all, smoke leads to coagulopathy, leading to the formation of pulmonary clots. Also, the stimulation of the sensory nerve endings that we have stated leads to release of neuropeptides. This release of neuropeptides will directly cause bronchospasm, leading to airway obstruction. It may also lead to formation of thick mucus secretion and cast formation, increasing the airway obstruction mechanism. Also, the airway epithelial exfoliation, as well as the increased airway blood flow. The increased airway blood flow will increase the formation of edema, added to the fluid therapy that we have mentioned about in the management of the burn patients, leading to airway obstruction. The reactive oxygen species and nitric oxide production will lead to cellular dysfunction, pulmonary hyperpermeability, leading to more pulmonary edema. All this lead to pulmonary dysfunction and hypoxia due to the ventilation perfusion mismatch. Acute respiratory distress syndrome in burn patients. This is the X-ray that we are all acquainted with, showing diffuse bilateral coalescent opacities developing 12 to 24 hours after injury, persisting for days to weeks despite the diuretic therapy. Pathogenesis of ARDS in burn patients, bacterial infection is more, free oxygen radicals lead to the genesis of the ARDS mechanism, the pro-inflammatory mediators, and increase in the fluid movement from the vascular area to the pulmonary interstitium. ARDS is one of the main complications in burn patients that contributes to the prolonged mechanical ventilation in such patients. It occurs in 2 to 17% of burn patients. The risk factors include age, injury severity score, acute kidney injury, and pneumonia. Compared to other causes of ARDS, the onset of ARDS in burn patients may be delayed up to 24 hours. And the timing of the post-burn ARDS varies with the etiology. Early ARDS occurs with severe inhalational injury and by extensive cutaneous burns. Later ARDS is maybe due to the pneumonia and other infections that occur. During the management of critically ill patients, the bedside clinician must always expect airway compromise at any time. He must be alert that at any time the patient may be obstructed and may be hypoxic, and he should be aware of how to manage an obstructed airway. Despite this, there is no conclusive clinical evidence to justify routine prophylactic intubation. It is not recommended in all burn patients to intubate such patients despite the risk of the airway obstruction that may occur. When is early intubation indicated? According to this study, which summarized the causes of early intubation into burn more than 40%, critical circumferential burn to the head, neck, chest, and abdomen. Glasgow coma score of less than 8%, of course, is an indication of intubation. Signs of respiratory distress in the form of stridor and shortness of breath, singed nasal hairs, and carbonaceous sputum. Fiber optic plays a very important role in burn patients or inhalational injury in general. It can be used to directly inspect the supra and infraglottic areas for edema, airway, for edema and for carbonaceous material. It classifies or helps in classification of the injury according to the abbreviated injury score that I will talk about in a few slides. And it helps in safely placing endotracheal tubes and in removal of mucus plugs, exudates, and foreign irritants. This is a study published in the Egyptian Journal of Chest Disease, which analyzed the role of the fiber optic bronchoscopy in management of smoke inhalational injury. And they concluded that in patients with smoke inhalational injury, fiber optic bronchoscopy obtained within few hours of admission was predictive of the total number of ventilator and ICU stay days, and predictive of the development of pneumonia according to the score that we are going to talk, the abbreviated injury score. This score includes 5 grades of injury, starting from 0, where there is no injury, and in the 4th grade, the massive injury, where there is evidence of mucosal stuffing, necrosis, and endoluminal obstruction. Treatment, strategy for treatment, of course, oxygen therapy is the mainstay, the standard. All suspected patients should receive 100% oxygen as soon as possible. Carbon monoxide poisoning is common in patients with inhalational injury. And of note that the half-life of carbon monoxide is normally 240 to 320 minutes. On giving oxygen 100% normobaric, this half-life decreases to 40 to 80 minutes, reducing the risk of the toxicity from the carbon monoxide. Actually, 100% oxygen should be administered for as long as it is necessary, or at least until the carbon monoxide concentration reaches 10% or less. Is there a place for hyperbaric oxygen? Hyperbaric oxygen may be considered for carbon monoxide poisoning, but there is little evidence to suggest that this hyperbaric oxygen improves the outcomes. And there is no consensus regarding the duration and the intensity of treatment. In addition, hyperbaric oxygen increases the risk of barotrauma in this patient population. Therefore, just oxygen 100% normobaric is enough and is mandatory in all patients with suspected inhalational injury. Securing the airway is very important, and it should be done as fast as possible. And it is very crucial in the outcome of such patients. Delay can result in difficult intubation and sometimes impossible intubation. Obstruction, problems in the airway management include obstruction, critical hypoxia, and death can quickly ensue after inhalation injury, even if airway is patent upon initial assessment. As I stated before, at any time, the airway may be obstructed completely, despite on initial assessment, there was no obstruction in such airway. In case of facial trauma or burns, it may also be difficult to mask ventilation. In such patients, the facial trauma and the edema and the injury that occurs on the face make it impossible or very difficult to mask ventilate such patients. But what about the intubation? What are the problems with intubation? Firstly, if we give an induction agent to help in intubation, it can result in obstruction due to relaxation of the upper airways, especially in the presence of upper respiratory tract injuries. Also, patients may have very swollen tongues, leading to difficult visualization of the airway. Awake intubation. Awake intubation may be the most suitable method for establishing an airway in such patients. This depends on the degree of airway involvement in burn injury. Awake intubation by the help of the fiber optic bronchoscope, of course. And if the patient is intubated, coming to us intubated, the endotracheal tube must be very carefully secured, as accidental dislodgement of the tube can be fatal. We might not be able to re-intubate such a patient. Tracheostomy is indicated when there is evidence or suspicion of vocal cord damage. A tracheostomy is the preferred method to prevent any exacerbation of vocal cord injury from an endotracheal tube. In patients already intubated on arrival at the burn center, the suggested approach in management is: first, the patient is intubated, then we should re-evaluate the criteria for intubation by direct laryngoscopy and fiber optic bronchoscopy. Classify according to abbreviated injury score. If the patient is class 0, where there is no injury, with no absence of carbonaceous deposits, erythema, edema, bronchorrhea, or obstruction, in this case, we can extubate the patient. If the patient is class 1 or 2, where there is mild or moderate degrees of erythema, carbonaceous deposits, and such injuries, in this case, we should assess for the past medical history, the clinical data, and the laboratory parameters and the imaging that has been done in such patients. And accordingly, we might extubate, or we might watch and wait for a while to assess the patient further afterwards. As for class 3 or 4, it's in which there is severe or massive injury, especially the mucosal sloughing, in such a case, leave the patient intubated and continue the management of these patients. Then about ventilation, this is an article that I recommend you to read. It was published in the European Burn Journal in September 2021, talking about mechanical ventilation strategies in the critically ill burn patients. The mechanisms that lead to ventilator-induced lung injury, as we all know, include the high tidal volume, volumetrauma, the high inspiratory pressure, barotrauma, repeated opening and closing of the alveoli leading to atelectatrauma, ergotrauma from the high mechanical power, oxygen toxicity, and lastly, biotrauma from the inflammatory cytokine release. To protect the lung from such injuries, a low tidal volume approach or technique for ventilation is recommended. This reduces the incidence of ventilator-induced lung injury. It reduces mortality in patients with ARDS. The target should be 6 milliliter per kg of the ideal body weight, minimizing also the driving pressure. The driving pressure is the difference between the plateau pressure and the PEEP and positive end expiratory pressure, targeting of a delta P of less than or equal to 15 centimeter water. This demonstrated an improvement in mortality. All these parameters are based on the alveoli study published in 2004, in which they investigated or tested the effect of applying higher versus lower positive end expiratory pressures in patients with acute respiratory distress syndrome. In this study, they concluded that whether high or low PEEP strategies, they both had similar outcomes. If the tidal volume was 6 milliliter per kg and the plateau pressure was limited to 30 centimeter water. This plateau pressure was the target at this period. Nowadays, we are targeting the delta P and not the plateau pressure, where the delta P should be around 15 centimeter water. The practical challenges in low tidal volume ventilation or lung protective strategy is: the inhalation injury itself may cause mucosal sloughing in severe forms, and the copious secretions and the hemorrhage. This requires aggressive pulmonary toilet to clear the airway. Also, the fluid resuscitation, the aggressive fluid resuscitation may result in pulmonary edema or intra-abdominal hypertension. Lastly, burn patients are hypermetabolic. This hypermetabolism increases the production of carbon dioxide, making adherence to the low tidal volume ventilation difficult, and the permissive hypoxia that permissive hypercarbia that we accept at sometimes may not be, we might not be able to target it. Patients with inhalational injury may require unconventional ventilation modes in the ICU. High-frequency percussive ventilation or volumetric diffusive respiratory mode and airway pressure release ventilation are two examples of the unconventional modes of ventilation. Regarding volumetric diffusive respiratory mode, it is a ventilation mode in which high-frequency subtidal volume breath are progressively accumulated until a certain airway pressure is met. At this point, passive exhalation is permitted to occur. To reduce, the main goal of the diffusive respiratory mode is to reduce the mean airway pressures and increase the overall arterial oxygen tension and PF ratios without adversely affecting the hemodynamics. Also, it has a goal of mobilizing secretions more effectively than conventional modes of ventilation. Some studies have suggested that the incidence of pneumonia is decreased in patients who are ventilated with diffusive respiratory modes. This represents the VDR. There is the flow created is known as pulsatile flow. This pulsatile flow bathes the alveoli in fresh oxygenated air while gently pushing the secretions and the carbon dioxide outside the alveoli with a very high frequency, which is the high frequency percussive ventilation. In simple words, high frequency percussive ventilation is a pulsatile flow that mobilizes and removes mucus and debris while gently recruiting the alveoli and restoring the functional residual capacity. This is another study comparing the high-frequency percussive ventilation versus the low-tidal volume ventilation in burns. But unfortunately, in this study, the high-frequency percussive ventilation-based strategies resulted in similar clinical outcomes when compared with a low-tidal volume ventilation-based strategy in the burn patients with respiratory failure. However, the low-tidal volume ventilation strategy failed to achieve ventilation and oxygenation goals in a higher percentage. This necessitated the use of rescue ventilation. Therefore, high-frequency percussive ventilation sometimes will lead to better outcomes and better results. The airway pressure release ventilation is another alternative mode of ventilation that may be beneficial in patients with burn. The airway pressure release ventilation uses high and low PEEP in order to recruit closed alveoli. As we have mentioned, the main problem in these patients is the atelectasis that occur due to different mechanisms. And therefore, improving or recruiting these closed alveoli will improve oxygenation. Essentially, it is a continuous positive airway pressure. It's a CPAP mode that is interrupted by an intermittent release phase. Here is the pressure time curve. There is a period of high pressure interrupted by a period of low pressure. The high pressure period is 4 times the low period pressure. We can say an IA ratio of 4:1. In this case, the P high, we have here different parameters than the parameters of the regular ventilator. We adjust the P high and the P low, and we adjust the time duration or the duration in which the patient in the high pressure part or the low pressure part. Airway pressure release ventilation results in improved oxygenation due to improved ventilation perfusion matching. Of note, there is decreased sedation and paralysis requirements. It has also been shown to improve the blood flow, not only to the lung, but also to the muscles of respiration and gastrointestinal system and the kidneys. To summarize, Several life-threatening complications such as airway patency, impairment, and respiratory insufficiency can arise in burn patients, and this requires adequate and timely airway management. Unnecessary endotracheal intubation should be avoided. Direct visual inspection via laryngoscopy and fiber optic bronchoscopy can guide appropriate airway management decision regarding the classification of the injury that occurs in the airway. Several mechanical ventilation strategies have been studied. The low tidal or lung protective strategy is almost always used, but at some times we might need the unconventional methods that we have mentioned. To date, there is no sound evidence that patients with inhalational injury should be ventilated with modes other than those applied to the non-burn patients. In all burn patients exposed to enclosed fire, carbon monoxide as well as cyanide poisoning should be suspected. And as we have mentioned, oxygen 100% is the best treatment for the carbon monoxide poisoning. Cyanide poisoning should be treated with hydroxycobalamin, and I didn't mention this because it was beyond the scope of the study.
Okay.
Thank you very much.
Thank you so much, Professor Waleed. It's very interesting. You covered two major areas, airway management and ventilation. At the moment, there is no questions, but I want to ask, you mentioned that there is inflammation of the oral mucosa and maybe swelling of the tongue as well. So is it easy to do fiber optic in patient with swelling tongue and inflamed upper airway? Actually, I don't have experience. I'm asking you about that here.
We use the pediatric sizes because you might need find the obstructed airway very severe, and the introduction of the fiber optic bronchoscope might be difficult if we use the adult one, but we use smaller sizes of bronchoscopies.
Yeah. And in one photo you showed us the patient with facial burn.
Yes.
Yeah. Facial burn also, it may be extremely difficult to ventilate, to intubate.
Yeah.
So what do you suggest?
To put a mask. I suggest if it's difficult to go for tracheostomy from the start, because these patients mostly have vocal cord injuries from the burn itself, most of them.
All right, yeah.
If he was not obstructed, he will obstruct from the edema that will increase by time.
All right. Do you think we should go ahead for tracheostomy, percutaneous tracheostomy, or any other procedures, not direct laryngoscopy or fiber optic?
We might go for the percutaneous tracheostomy. Actually, we used percutaneous tracheostomy several times in such patients, but it was not that easy because facial and neck burns usually occur simultaneously.
All right. A question from Dr. Wissam. Is it possible to use topical lignocaine to do a weak fiber optic with sloughed mucosa, severely inflamed mucosa or sloughed mucosa? Is it easy to put lignocaine?
Actually, if we find the sloughed mucosa and it's difficult to get approach to such an airway, we always go for the tracheostomy from the start in order to save the patients from the problems that will occur.
Yeah, okay. Actually, there is no more questions, and thank you so much, Professor Waleed.